We are live now, doctor.
You. Good evening, respected senior colleagues and all the wonderful and dynamic residents who have logged in today. I am Dr. Vishal Agarwal, Scientific Committee Chairman, ROS, Rajasthan Ophthalmological Society. And it gives me immense pleasure to welcome you all for yet another masterclass of the online PG teaching program Kaksha. Kaksha is a PG teaching program by Rajasthan Ophthalmological Society, which will cover all the major topics of the postgraduate curriculum. We'll be bringing the best of national and state faculty experts to share the knowledge and interact with you. The residents are also encouraged who have logged in to put forward their doubts in a fearless manner, either by raising their hands or typing in the chat box. As usual, there is a small informal quiz kept at the end of the class with lots of prizes to be won. So keep a strong vigil and stay glued to the class. Coming to this class, we have today with us Dr. Pradeep Venkatesh from RP Center, AIMS, New Delhi, to teach us and enlighten us about the common retinal conditions and the tips for their diagnosis, clinical diagnosis, especially without the aid of expensive diagnostic modalities, as sir told me and briefed me before the class. It is a very important topic, not just for the postgraduates, but also for all practicing ophthalmologists. Dr. Venkatesh is my guru, teacher, and guide since 2 decades. And besides that, he is a VR surgeon par excellence, academician, and a teacher par excellence, and is an authority on all things retina. I welcome the ROS President Sanjeev sir, President-elect Dr. Virendra Agarwal sir, and our dynamic secretary from Jodhpur, Dr. Ghulam Ali sir. Good evening, sir. We have a couple of residents with us. Tapasya, Praveen, are you there?
Yes, sir.
Okay.
Yes, sir.
Kiran, Anirban. Sir, Pradeep sir, these are all postgraduate students from AIMS Jodhpur, and they are on the hot seat. Hot seat means that you can interact with them. You can ask them questions in an informal way, and they can ask queries to you over the chat box. I will moderate the session, no problem. So over to you, Pradeep sir, for the class. You can start.
Thank you, Vishal. And Vishal has been very kind to say those words about me. But I mean, Virender is also from RP Center, I think. It's the same Virender Agarwal, right?
Yes, sir.
Vishal?
Yes, sir. Yes, sir.
So Virender has been my senior and brings back very fond memories of the time we've spent at RP Center. Very good evening, Virender, to you.
Good evening, sir.
So today's class, essentially, I thought, I'll have this kaksha through a lot of kathas, meaning a lot of stories. And like Vishal said, I mean, there's a lot of, movement that's happened from the joy of clinical diagnosis to the mundaneness of depending on investigations. So whatever I'm kind of going to present today, there's a collection of the last maybe 2.5 decades or so. And all of these stories are true stories. Okay, nothing has been made up. And it's about the small details that my teachers paid attention to. We learned from our teachers. And so that's what I'm going to be presenting today. And for all of you who have joined this class, I'm hoping that maybe 60 minutes or 70 minutes is actually will be of some value to you. And so let me begin with the diagnosis itself. When we say we take the clinical diagnosis or the diagnosis itself very lightly these days, because we just say, okay, somebody walks in and then we just do a very casual examination. I think the detailed examination that my teachers emphasized upon is no longer actually done in real situations. So why is diagnosis so important? I'll tell you about what happened to me actually. Okay, so around 10-12 years ago, I started developing some small blisters on my fingers, and then it was itchy kind of blisters. And I thought it would go away. I didn't do anything about it. And then I saw that it's sometimes significant, sometimes not significant. Vishal, am I audible?
Yes, sir, clearly.
Hello?
You are audible, sir. You're audible.
Okay, so I had these small blisters on my digits, okay, and then I went to the dermatologist and at AIMS itself, and I showed it to him, and he was a faculty over here, and he said, I'll prescribe the steroid ointment, and then you apply and they'll go away. but I'm not very comfortable taking any kind of medicine. I try to resist as much as I can, and so I never did anything about it. I let it persist. Then it so happened that when I used to do fluorescein angiographies, I mean, those were early digital camera days, so I would wear the gloves only in my left hand to lift the patient's eyelid. I mean, I would do the angiographies myself, the photography myself. So then I realized that I was having these kind of lesions and itchiness only in my left hand where I was wearing my gloves. And obviously, it turned out that I had latex allergy. And then now, I mean, I have absolutely no problems. I'm using non-latex gloves now. So if I had not actually made a proper diagnosis, it took me some time on working on this myself. Now, if I had not made this diagnosis, one thing I would have started myself on some treatment which is so non-specific, there would not have been any long-term cure. Okay, intermittently, I would have had to continue. I would have exposed myself to the risks of steroids. Obviously, I mean, you would have caused harm, and that's the way we probably cause harm to our own patients. And the series of stories that I'm going to tell you is where we exposed our patients to harm, and maybe that could have been avoided. Okay, so here again, I'm just going to present a series of photographs, and I would request the participants to take. Vishal, can you just moderate this particular bit?
Yes,
Can you
sir.
just
I'm
tell me?
moderating. And sir, Dr. R.K. Sharma, he's the
Yeah,
senior post
yeah,
VR surgeon. He'll also moderate in between.
yeah. I just request them to just type in their diagnosis to each of these slides, maybe in 30 seconds or a minute, whatever comes to your mind. Okay, these are actual clinical photographs, and then
So,
I'll
sir
come
will be
back and tell you.
showing the slides, and the residents are requested to type in their provisional diagnosis in the chat box.
Yeah, so I'll come back to the stories on all of these patients subsequently. Okay, so there's not going to be much of text that I'm going to be presenting over here. It is just simple stories related to patient history. Okay, so Vishal, when you tell me to move to the next slide, I'll move. Yeah.
Sure, sir. So this is the slide. This is a fundus photograph, and this is the angiography, and you can type your provisional diagnosis, whatever comes in your mind, and then we'll proceed. So you
Yeah,
can keep in typing.
yeah, and I'd also encourage you to make mistakes. Okay, this is the time to make mistakes so that in the real world scenario, those mistakes don't happen. So don't hesitate to make mistakes. Okay. Yeah, moving to the next page. Okay, this is, I don't have the actual patient picture over here. So this was a private ward patient operated by my professor. And then the patient had actually got admitted in the private ward again. So it had operated on this lady 3 days earlier, and then she had come back with some increased blurring. Okay, and she had been admitted in the ward. So what would your differential diagnosis be, or what would your diagnosis be? She was, like I said, readmitted in the ward. Okay,
Keep
on
on
these
typing
kind of
the response.
situations, you would definitely.
Yes.
Yeah. Okay. So this is one situation. Can I move to the next, Vishal?
Yes, sir. You can. You can. So the
Yeah.
first
Okay.
response
So
is BRAO.
no, I think we'll come back to this thing later on. Yeah. We Yeah. So again, here I'm emphasizing here also that this was a private ward patient, because many a times, what happens if it's a general ward patient or a simple ignorant patient, a lot of wrong things happen and they never come to light. Okay, so here I'm emphasizing that these are patients who had best hands seeing these patients. Okay, so that's the reason. This was a private ward patient. Again, this is a situation where she was the husband of one of our senior sisters over here, and he came back 2 months after phacoemulsification with redness and photophobia. Now, again, here, what would your diagnosis be? I think I'll move to the fourth
The
one.
resident should keep in mind what are the complications of phacoemulsification. Then only you will be able to think of why the patient has come back.
Yes, yes, yeah. And this is something that actually happened to me when I was, I think, assistant or associate professor. He was a doctor himself, and then he walked into my office. Okay, so and then he came with a printout, OCT printout, showing a neurosensory detachment. So, what would your diagnosis be?
You will be showing the OCT, sir, or we have to
No, it is a normal neurosensory detachment. I think they'll all
Okay.
know how a neurosensory detachment looks.
Okay.
So there was nothing unusual about the printout. It was just a plain neurosensory detachment. And like I said, these were time domain days, Vishal, so long back. So
So the chat box says CSCR,
yeah, so
CSC.
we'll go to that this thing, discussion subsequently, Vishal. Yeah,
Okay. Okay.
yeah.
Okay, sir, you can
Okay.
proceed.
Yeah, so this is the next patient. Okay, he's again, I'm emphasizing, he's a very rich patient. He's shown the best hospitals in Delhi. He's come for a third, fourth opinion. His vision has been 6/60, and he says there's persistent or increased blurring. He had been diagnosed with intermediate uveitis. He's been given a lot of corticosteroids, and when somebody said you start yourself on immunosuppression, he wanted another opinion. So he'd come with three of his relatives. Actually, I still remember that day. He'd come to the retinal lab with three of his relatives. And obviously, when a rich patient comes, it's very difficult to maintain a sort of this thing, asking them, the others, to wait. But that was the situation. Okay, so what would you consider in this situation? Yeah, I'll move to the next.
Yes,
Uh,
sir.
yes, yeah, okay. Yeah, this was a child again, post-traumatic, and referred as post-traumatic dislocation or lens matter in the anterior chamber. You see the image date is 2002. Okay, this was taken by me almost 3 decades ago. Okay, 3 decades, 2 decades ago. Yeah,
How old is the kid?
pardon?
How old is the child?
The child is 6 years old.
Okay. And this is the unilateral involvement.
Yeah, unilateral involvement. Yes, with history of trauma.
The trauma was penetrating or blunt?
No, it was a non-specific trauma, sir.
Okay.
Yeah, this is again, I think, a diagnosis. So I would like you to just write down whether what the actual findings are. What is the grade of retinopathy that you're able to see? Vishal, is the image all right? The quality of the
Yes,
image?
the image is clear.
Image is clear. Yeah.
They can zoom it also on their mobile.
Okay, sir.
So this image is quite clear, sir. It's the right eye
Okay.
fundus image.
Yeah. So this should not be very difficult. Okay. Yeah.
Yes.
And now this is another patient. Now this is a bilateral presentation. You're seeing these multiple lesions like that. There's some exudation there at the macula. You're seeing the detachment there. So what would your diagnosis be in this situation? The reason I'm just showing you the pictures is I think most of us just have our indirects on and we just have the patient coming in. We see this is what we're going to see immediately. Okay.
Okay, sir. Okay.
Yeah. The next. This is another patient. Okay, you're seeing a more severe involvement in the left eye and an early involvement. The inferior field is showing some kind of a change inferiorly, some localized detachment maybe in the right eye, but a more severe and obvious involvement in the left eye. So, what comes to your mind over here?
Right eye inferior involvement, left eye macular involvement involving the disc.
Macular rest and superior retina. I mean, more severe involvement is there in the left eye. Yeah.
And sir, age
And
of
the age and gender also is important in this case.
He's a
So
male. He's a
if
male patient, sir. I think he was around 45, 48 years old, male patient.
okay.
Yeah, so now this is another patient, bilateral involvement. This patient was also around 40 years or so.
Okay, sir.
Yeah, Vishal. Okay, this is during the analog days. We didn't have digital cameras, so this image was taken by me during maybe 97, 98 when I was a senior resident. So this image is not very sharp. It's been stretched. Okay, so it was probably more pixelated over a not very sharp image, but this was how the left eye appeared. Okay. Sorry, I don't have the color image of this patient.
Okay, sir.
This was again, I think, 35-year-old patient, and this is all he had. The image is rotated over here. The image is inverted, so that again. And move to the next, Vishal.
Yes, sir.
Yeah. So this patient was again referred to the uvea clinic as a patient with uveitis. Okay. So this is the appearance. Yeah.
Any idea about the profession of this patient, Dr. Venkatesh?
Oh, no, I don't recall the profession. Actually, these are all again 2001. It says the images of 2001. Long collection of cases.
Yeah. Good collection, but
But nice
I,
photograph for that age. 20 years back, it's quite a crisp photo.
yeah, no, we had the ICAP image that had just come in, Vishal, to the glaucoma lab, no? So
Okay.
I used to take the images in the lab at that time. So these are the hack straight ICAP images.
Okay, so you can move to the next slide.
Yeah, and also please make a diagnosis for the other eye, both the eyes. Try and write a diagnosis for both eyes, okay? Yeah. These are two different children, okay? Both of them have these kind of hypopyon over here. And I think both of them were 4 years, 5 years old. So please make a diagnosis. Just write down your diagnosis.
So 5 years old, you said?
Yeah, 4, 5 years. I think the right hand side was 4 years, and the left hand side was 5 years old.
though the iris is not very clear, can you give some idea about the intraocular pressure here?
The intraocular pressure was normal.
Okay. So that the residents can have some idea at least.
Yeah. No, and it's I mean, nice that you're getting in these other points. There's a lot of learning from those points also. It emphasizes on what Sir is saying, looking at the other aspects, intraocular pressure, whether there is iris neovascularization, neovascular glaucoma. These are points that are very, very important. And many of these things that I'm showing you actually is also a tribute to my teachers, okay? Because whatever we know because of my teachers, and they've been very excellent in their clinical skills. Yeah.
Sure, sir.
Yeah, and this is another patient who came. This is again during the early digital days, not a very, very sharp image that you're seeing. Okay, but this is how the patient. There was a bilateral involvement. I don't have the other eye image with me.
So this was a chronic condition, or the patient came with the acute presentation of vision loss?
No, this patient was chronic, actually referred. Many of these patients have been referred or they've come after being treated for some time elsewhere. Uh,
Okay, sir.
yeah. It was again a young girl of 9 years, the bilateral presentation like this.
Any systemic history associated, sir, or in the history you know of? You remember?
No systemic history, no known systemic history, Vishal.
Okay, sir.
Yeah, so now we'll come around to discussing each of those slides that I've shown you. And Vishal,
Yes, sir.
my request is I don't have separate quiz slides because I thought when you said so this is more like that. So you choose
No
any
problem, sir. I'll choose
any
them.
of these two slides if you
Sure, sir.
want. Okay, and
Sure.
please decide on that. Yeah,
No
now
problem.
this particular, yeah, so the first image that I showed you was of an elderly lady, so she was being seen. This happened again when I was a senior resident, and she was being seen by some of her young faculty, and then was getting treated with steroids, and then finally a diagnosis of possible tuberculoma was made, and the patient was admitted in the ward. And during the ward admission, we said, okay, let's get a systemic examination done. Okay. And yeah, the systemic examination also actually was not done initially. So it was decided that since we didn't know what the nature of this particular lesion was, it was decided that we'll do a biopsy. So in that whole interim period, we got a systemic examination done, and during the systemic examination there was mass abdomen. Okay, and meanwhile the biopsy had been done. We somehow getting investigations done for the abdominal mass, and then the biopsy had been done because typically the surgeries are done within 3 days. Okay, so the mistake that could have happened over here, we should have waited for the abdominal mass, because imaging that, biopsying that would probably have been better than doing a biopsy of the mass itself. Okay, so when the whole diagnostic workup was done, it turned out that the patient had an ovarian carcinoma, and this was a metastasis to the eye. So this patient initially had been treated with steroids, and there was talk about starting anti-tubercular treatment. Okay, and also because there was some kind of a lesion on the chest. And obviously, in our situation, any chest lesion we believe is tubercular, and we would have erred on the side of giving her anti-tubercular treatment, but for a systemic examination. Okay, so whenever you have a mass lesion like this, an elderly lady, you should be cautious. Okay, don't get carried away that it's tubercular and start these patients on ATT, because and the image that you're seeing bottom right is essentially after radiotherapy. Many of these metastases, they respond very well to very well to radiotherapy. Of course, these were days when you didn't have targeted chemotherapy and those newer immunotherapies and all that. So essentially, radiotherapy was given to this patient, and the histopath you're seeing there showed up metastasis from ovarian carcinoma. Okay, and these were seen by, like I said, the young faculty. And at that time also these mistakes can happen. And when you say tuberculoma, where we would have erred is not look for cells. You would have had definitely cells. If you're seeing such a large tuberculoma, you would have had cells in the anterior chamber, maybe some cells, but retrolental vitreous cells would definitely have been there. Obviously that was not recorded or was missed. Okay,
And so
So
what are
this histopathology is from the abdomen or from the eye?
so this is from the abdomen, the ovarian mass.
Okay.
Yeah, so this again was when I was a senior resident, and it was operated by the chief at that time. And so I mean, I happened to meet sir in the ward, in the private ward, and then he said, "This patient is admitted. Please have a look. Why don't you have a look?" Okay, the patient has already been treated, and patient had been started on intravenous. The vision was 6/9, so intravenous antibiotics alone had been started for this patient. Okay. Then I went and spoke to the patient, and there were no other symptoms except for the blurring. There was no other symptom that this patient had. So I said, okay, let me just again have a look on the slit lamp. And what happened on the slit lamp was the amount of cells that were there in the anterior chamber was commensurate with the 3-day-old cataract surgery history. Okay, but what was most revealing, and since this patient was already on steroids and cycloplegics, the pupil was already dilated. But what astounded me was the amount of pigments that were there in the retrolental space. And when you see retrolental pigments like that, you should always consider the possibility of a new break formation that is there, or the risk of a posterior vitreous detachment. It's very unusual to have posterior vitreous detachment so soon after cataract surgery. I went on to do an indirect, and this patient had a large or easily visible horseshoe tear. Okay, so the whole thing changes, and whenever you see this blurring, immediately you think of endophthalmitis, and you're not doing a complete examination. So for me, it was just looking at the pigments in the retrolental space that changed the situation for this patient. And obviously, she was lasered, and then she was discharged. Okay. So the emphasis, and we see the anterior chamber, that the retrolental space has a lot of importance for us. Please don't miss that. Okay.
Sir, but why would the PVD occur just 3 days after uneventful cataract surgery?
No, no,
Or
it
it
may
was a
be.
mature cataract and you could not see before the surgery, and now you can see because now it's pseudophakic, the retrolental cells.
Uh, No, see, I don't know the prior history because sir had just operated on this patient. I really don't know what the vision was before her cataract surgery. It was just that she was getting managed as probably a low-grade endophthalmitis. So I'm just trying to emphasize now whether the PVD coexisted before or it was an event that happened immediately. It was a concurrent. I mean, like I said, it's very unusual for PVD to happen within 3 days, but it could be coincidental that the PVD, she was anyway due for PVD and it happened 3 days after the cataract surgery. It is just a rare event. But the presence of pigments in the retrolental space rather than cells in the retrolental space made me look for a tear, and she had a tear. Okay,
Okay.
so just, yeah,
You,
so I'm just
you, you,
emphasizing.
so, Dr. Venkatesh, so the point is, yeah, we must look for cells in the retrolental space, and at the same time, even if you are suspecting endophthalmitis, you should do an indirect ophthalmoscopy before you go ahead with intravitreal injection.
Yes, sir. Yes.
Because
Yes.
if you give intravitreal injection in this situation, he would have developed a detachment.
Yes. Yes, sir. Yeah, that's the emphasis. Okay, what sir is mentioning. This happened just a few months ago. He was operated by one of our young faculty, a very good phacosurgeon, and then she came, said this patient, so he's had operated, and now 2 months later he's got cells, and obviously there is worry of endophthalmitis in this situation. The patient did not have any past history of uveitis and all that, and the cells were also not significant. It was 10 to 20 cells that were there. But what prompted me to not consider endophthalmitis in this patient was absence of cells in the retrolental space. He didn't have a single cell in the retrolental space. So I said, we will hold on. We were not going to immediately give and treat him as endophthalmitis. But obviously, when you take a decision like that, it means that you're going to follow up this patient for the next few days, every 24 hours, every 48 hours. You're not going to take a call saying it's not endophthalmitis, you come after a week. That is not what I'm emphasizing. The emphasis is that when you choose to observation as a treatment, it means you're going to have a close follow-up also. Okay, so in this patient, now, an interesting thing that happened with this patient was he got control and the retrolental space. I mean, I've been following up this patient even now. He came this Monday also for a follow up. So he's never had retrolental cells. This is subsided with steroids, and subsequently the other eye which had been operated more recently. So that I also developed some cellular reaction in that eye, but again, no retrolental involvement. And meanwhile, I got him evaluated for ankylosing spondylosis. MRI had never been done for the spine region, and MRI is showing some early features. Okay, they've not started him on any kind of disease modifying agents, but there's a likelihood that he may be an early ankylosing spondylosis patient also. So the emphasis again here is that it may not always be endophthalmitis, and endophthalmitis means retrolental cells have to be there. Okay, so without that, you have just a close follow-up and close observation with the normal treatment for uveitis. Okay, so he had just anterior uveitis. Again, emphasizing the importance of evaluating the retrolental space.
Okay, sir.
And in between, if you have any questions, we can consider it anytime. Yeah.
You can ask your questions. You can raise your hand or chat, type in the chat box. Anybody.
Yeah, this is an interesting incident. Like I said, he was a doctor himself. So I just finished my OT and had just come into my office. So he came there holding a printout of OCT showing a neurosensory detachment, and that printout had been given to him by one of very good institutes in the north itself. So he said he had already been seen there, and they diagnosed it as central serous retinopathy, and they'd given that printout to him. So since he had been seen by, I mean, experts, I know the institute, I know the people there, and they're, I mean, wonderful people, very good expertise. So I didn't even see him. I said, if they've made a diagnosis of CSR, I don't even have to see you. And I just reassured him and I sent him away. Then the story goes forward 1 year later. Okay, that institute where he had been seen was actually holding a annual meet, and then at dinner time, I happened to see him. So I went and just asked him how he was doing, and then what surprised me was he said he had developed symptoms in the other eye, and then ultimately it turned out that he actually had Harada's disease. Okay, it was not VKH, but he had Harada's disease. Now, every single time, I mean, during my senior residency and early days also, there's always an emphasis that when you have a neurosensory detachment, you should look for cells. Okay, and in this situation, again, anterior chamber cells, retrolental cells, and in the early stage of Harada's disease, you may have cells only in the posterior vitreous cavity. Now, I'm again emphasizing this was seen by some of the best retina specialists, one of the best institutes, and the basic kind of, even I would have made the same mistake. Okay, so for as youngsters, every CSR that you see now again become with a printout like this. You please document that there are no cells. I mean, I've always made it a point now that I tell my residents, I do it myself. I clearly write there are no cells, at least to emphasize that you're considering this probability. Okay, so all neurosensory detachments are not CSR. Okay.
Yeah, and if you look at with the indirect ophthalmoscope, you will see multiple CSR-like lesions in the fundus. So fundus examination with indirect is also important in these cases.
Yeah, yes, sir. But there's probably, I think they would probably have had only a macular detachment, so they would have probably not considered that. I mean, like sir is saying, usually the multifocal detachments that you see in Harada's disease patients, okay, very rarely you can just present with a macular detachment. But again, when you have a macular detachment, the disc is always hyperemic. When patients with Harada's disease, almost always that disc hyperemia gives it away. And
Yes.
also the vision is, yeah, vision is never commensurate. Like a CSR with a macular detachment is likely to have 6/9, 6/12, but a patient with Harada's is likely to, will definitely have 6/36 vision. Okay. So,
Another thing, Dr. Venkatesh, the patients with Haradas will not have a clear fluid in the subretinal space, while a patient with CSR will have clear fluid.
very true, sir.
So
Very
it will
true.
be hyper echoic actually.
Very true. Yes, sir. Yes. Yeah. But probably it was an early kind of a phase, and that's why I think we missed in that
Yeah, it's
doctor.
possible.
Yes,
Right.
sir.
Yeah.
So this the next patient again, he came into the retina lab, and so he came in, like I said, with many relatives with him. And then what surprised me was that the media clarity was not a 6/60 media. Okay, so obviously when you would say 6/60, you expect the media to be hazy, some cataract, something causing that 6/60 vision, and it was not like that in his case. And then I only asked him to do one thing. I asked him to show me his palms. Okay, and his palms clearly had the plantar or the palmar rashes of secondary syphilis. Okay, and what was most shocking for me was I told him, did you show this to your doctors? He said, I have shown it, I mean, to one of the most big private hospitals. Okay, I mean, I'll tell you, the Apollo Hospital. Actually, he had actually shown the dermatologist over there, and they said it's a fungal involvement, and he had been given an antifungal cream. Now, that was something that was grossly shocking for me, but I'm again emphasizing, so don't get carried away that they've been seen here, seen there. You've gone through these basic training to apply yourself. And in this situation, it's a touchy kind of a thing asking him about HIV and syphilis and all that. But then I asked him why, but I said that we need to assess, otherwise we can't really change your outcome. And all of it turned positive. The moment you're thinking of syphilis, HIV and syphilis go together. And in his case, HIV was positive, TPHA, VDRL, all of them were positive. he never came back to me, obviously, because there's a lot of social things that set in once you have these kind of positive reports. Okay, so this is something that can happen, and again, emphasizing this was way back. Okay, but now CDC in the US is also reporting a spike in syphilis, and over the last 1 year, I think we ourselves have seen more than 10 or 12 patients presenting to us with syphilis. Okay, there has been an uptick of syphilis post COVID. I don't know. I really don't know why. So if you're seeing patients like this where the vision is not commensurate and you're not able to explain, don't hesitate to get the testing done for syphilis. Okay. So
In
we
all
have,
cases of anyways, in all cases of UVI tests, I think all the tests, including HIV and Papilloma pallidum assay, should be done, especially if it is not improving and if it is recurrent. Do you
yeah,
agree?
yeah, atypical cases. Yeah, yes, atypical.
Right.
Yeah, no, this is the young boy I said. Now I'm just showing you the other pictures also of the same child. Okay, so what you're seeing here is essentially vitreous seeds. If you see the lower images, and obviously this patient had a retinoblastoma. These are not this is not lens matter just floating in the anterior chamber. These are iris deposits. Okay, obviously a very advanced stage of retinoblastoma. So the history of trauma sometimes can be very misleading, and please again evaluate the other eye. Now I'll come back to the other eye examination in the subsequent kind of photograph that I have. Okay, so this is not lens matter. This is a advanced stage of retinoblastoma.
Can you go back to the previous slide, sir?
Yeah.
So many residents answered juvenile idiopathic arthritis JIA in this
Okay.
condition. Can you tell me or can you tell us about the differentiating features? Can it not be a acute anterior uveitis with a lot of flocculent matter in the anterior chamber?
Yeah, so the differential diagnosis here would be a hypopyon uveitis. Okay, so hypopyon uveitis is very unusual in a child, and again, the emphasis is if it's a child or an extreme or a very elderly patient, two extremes of age, you should strongly suspect a masquerade syndrome. Okay, that is one. The second thing is juvenile rheumatoid arthritis is a chronic kind of a uveitis. The pupil is never going to be so regular and dilated like this. The pupil is dilated at regular over here. And the first thing that hits GRA uveitis is the iris and the pupillary distortion that happens. Okay, so you're seeing none of it over there. It's relatively quiet, yes, as in terms of GRA is a quiet eye, but other than that, the pupillary involvement you're not seeing at all, and it's very unusual for you to see these kind of flocculent matter just floating in the anterior vitreous. Okay, here it's actually attached to the iris. They're not floating in the anterior vitreous, but sorry, in the anterior chamber, but they're all stuck to the iris. Okay, these are iris deposits. So juvenile rheumatoid arthritis almost never will have a hypopyon also.
And the juvenile rheumatoid arthritis will have some corneal degeneration also if at all.
BSK, yeah, so band-shaped keratopathy. In more advanced cases, you could have band-shaped keratopathy.
Yes, sir.
Yes.
Okay, sir.
Yeah. I put up this kind of slide. Essentially, I think you were all able to see the neovascularization elsewhere, but I'm not sure how many of you picked up the large neovascularization at the disc. Okay, so when you talk about the ETDRS classification or the ETDRS grading, they chose 30-degree fields. What you're seeing on the left side, the photograph that I've shown you, this is a 50-degree field. That's not an adequate magnification. So whenever you kind of want to pick up or comment on something, you need the ideal kind of a situation or the ideal kind of a field. Like you say, for the glaucoma field, edge defects should not be considered for making a diagnosis of glaucomatous field. Okay, so in this, I've taken the same patient's picture with the 30-degree field centered on the optic nerve head, and now you can see all these abnormal bezels that are so easily evident. Okay, so sometimes with these smaller images, you can miss these proliferations. So always try to get the ideal situation and only then make a full diagnosis. Okay, obviously here the treatment would have been the same. You would have said there is an NV, anyway, let's go and do panretinal laser. But the important thing is that we've missed a large NVD. And the next thing that I'm emphasizing over here is the red-free image. Okay, and you don't have to do fluorescein.
Excuse me, Dr. Venkatesh, if you go back to the previous
Yes,
image,
yes, sir. Yes.
the message to the residents is don't rely on indirect only in cases of diabetic retinopathy. Always do the slit lamp biomicroscopy and you will never miss these NVDs.
Yeah, very true, sir. Very true.
Yeah, please go ahead.
Yeah. Okay, so the next thing when you're talking about retinal images, no, you don't have to do fluorescein like this on Tuesday the rounds I was asking question immediately the answer residents would say is we'll do a fluorescein angiography. You don't really need to do a fluorescein angiography, and it's not at all recommended by the ETDRS. Okay, all the classification grading is based on imaging, and they also did red-free imaging, but they said that the yield was not very high with red-free imaging. But trust me, when you do red-free imaging or emphasize or take those images, see here, you're seeing an IRMA. If you had just, I don't have the corresponding color image of this. So this is an area, now it will change your grading, okay? A presence of IRMA, one IRMA, two IRMA is going to change your grading itself. And now going back to the previous kind of a slide, I'll tell you the mistake that I made myself. Okay, this happened again maybe a decade ago. A patient came back and he was referred to one of my colleagues. And for some reason, that patient came back to me, and I was aghast. And it was written, it was seen by somebody in private setup over here saying that there was NVT. And I had seen him maybe a few weeks before and had just written as a severe NPDR and had not mentioned the NVD. And I felt very disappointed as to how I missed the NVD. And then I went back and I almost always capture fundus images of my patients. Okay, so I went back and these were again the Zeiss camera. So I went back and saw the images that I had taken. And the consultant to whom he had been referred now that I had missed an NVD, he also happened to be there, or I requested him to come over. And then I put up that same image that I had made a diagnosis with. Okay. And then he also made same diagnosis I had made. And then I showed him that this patient had been referred to him by, I don't remember who in Delhi, but somebody had picked up the NVD and referred it to him. And then what had actually happened was that was a flat NVT that was slightly elevated. Okay, it was a flat elevated NVT, and I was focusing sharply on the retinal surface. And when I defocused and I showed it to my colleague also, that is the mistake that had happened, that it was completely on focus on the retina. So sometimes these subtle changes you can miss. Okay, so you have to be a little more cautious. And like I said, it happened to me that I had focusing on the retina, but it was an elevated new vessel which had missed, a flat elevated new vessel. Okay, it was almost a flat. What you're seeing over here. So then, I mean, in a way, it was this thing that my colleague had also not made the diagnosis, seeing the same picture, but at the same time, it's no consolation. Okay, because you're missing a very grievous kind of a situation. I should have done an immediate pan-retinal laser, which I did not do, and luckily for the patient, somebody else had picked it up, and obviously he would have got treated. Okay, so that kind of a mistake can happen. So when you're using these cameras, like sir was saying, doing a 90D, try to focus also front of the lesion, the front of the new vessels, front of the main area NVT, okay, so that you don't let such a situation happen. And even there, and like I said, I normally take the red-free images. For some strange reason, I had not taken the red-free image for this patient. If I had taken a red-free image, there was no way I would have missed the NVD. Okay, this orange on red on orange is more difficult to pick up than a gray on black. Okay, so a red-free image also I had not taken in that patient. So this kind of an error can happen. Okay, so the emphasis is to avoid such a mistake.
And so with the advent of the wide angle systems, the wide field imaging systems, do you think that these diagnoses are more less frequently missed nowadays because they give a high resolution, they give the whole field as compared to the ETDRS, they give a 200-degree field in one shot. So the chances of missing these diagnoses are less likely nowadays than before. If you're just
Uh,
seeing the fundus photographs, I mean.
Yeah, no. I'll take a counter stand to what you're saying, Vishal, because the reason is that it gives you a wide field, but the field is very magnified. So unless you make the effort of zooming in, like even when now I use the optos very frequently, uh, so there also I make it a point to read all the seven fields that the DDR has emphasized. I zoom in first to the disc, then move it to the macula, then field 3, 4, 5, 6, 7. I move into all the fields, but in a zoomed manner. With a minified, if you just look at one large image, 200-degree field, you're definitely going to miss the earlier. When there is a very large new vessel, obviously you will not miss, but it's about picking up those early lesions. And the wide field is not an ideal kind of screening modality to pick up early lesions. And even now, it's not.
Exactly.
Yeah, yeah,
Exactly. I
yes,
agree with you. And Vishal, I also agree that the more field you get, you have to either zoom and you have to look for a place. You can't zoom whole of the fundus, and that takes more time. So it's better to get a magnified view in central fundus at least.
Exactly.
yeah.
Point.
Okay. Yeah. And again, as youngsters, one of the things that worries me is that with the wide field, we're becoming like radiologists now. And I mentioned this to my colleagues and my friends in jest, okay, we're sitting in an air-conditioned room, the optos is there, we're just using the mouse and scrolling in, scrolling out, but we're totally losing touch with the patients. Okay, so as youngsters, there'll be a lot of temptation to be like that, but please don't become like that, because what matters ultimately, with so much of AI coming in, you'll not be valued for your diagnosis. You'll be valued only for your patient handling skills and the treatment that you're going to offer. Diagnosis is going to be taken away by the technology. So your only presence with your patient is going to be how you're going to reassure him, tell him what the prognosis is, how you're going to manage him. That is what you're going to be valued for. Okay, so don't kind of get so used to depending only on the technology. Okay.
Right, 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 right.
Yeah, so this obviously now you have the fluorescein angiography over here. So it's normally said that in CSR you don't have these kind of hard exudates, but in a chronic disease you could have hard exudates. Very rarely it is known, and obviously these yellow lesions, and we vitreoretina surgeons are very error prone. We just use an indirect, and then we see these yellow lesions and immediately make a diagnosis of choroiditis when it's actually fibrin deposits of CSR, and then we put them also on steroids. So this is what had happened in this patient. Somebody had made a diagnosis of choroiditis and they put the patient on steroids, and he had developed a massive exudative detachment in both eyes. Okay, and obviously fluorescein angiography is very revealing. You're seeing these multifocal leaks. Okay, so again here, if somebody with choroiditis, you're going to have cells, at least in the retrolental space. So no effort has been made to look for cells, and no cells means no inflammation. Okay. So this patient was seen in 2008. I think that you see the dates over there. So he again came to us with a sequence of follow-ups that was there. Okay, this is a left eye follow-up. He was started on steroids and then he was started on ATT. Initially, steroids seemed to have worked and then it seemed to have become resistant. So somebody said we're going to give ATT. And then when he came to us, he had this hand movements vision when he came to us and diagnosed as resistance to ATT. And this is the right eye image, and then you have the left. Sorry, that was the left eye. And you're seeing this. Okay, obviously the right eye lesion has also increased over a period of time, and you're seeing an exudative detachment that is there in the situation. Now, if you go back over here, unlike the earlier, is my cursor visible, Vishal? Is my point?
Your pointer is visible, sir.
Pointer visible. Yeah. So unlike the previous one, if you see, if you see these, okay, the retina here doesn't look very tense over here. Okay, but if you go back and see how tense the retina here is, okay, you can probably think that there is something happening beneath the retina, just not fluid accumulation, but something else possibly is there. Okay, so with that suspicion, again, none of these patients actually give you a history of any systemic involvement. So you do an ultrasound and then you see what you're seeing, these kind of subretinal uh, mass lesions over here in both eyes. And obviously, the diagnosis now is of a bilateral metastasis. Okay. So this patient who had metastatic eye disease in both eyes, which was unfortunately again diagnosed as choroiditis because of the lesions that are there. Again, you would have not picked up for cells. And then what also you see is that is you do a CT, and then there was abnormality in the lingula. There was consolidation, and they were not very sure actually whether it's actually a tumor. So they went. It was all done at AIMS only. So they did a bronchoalveolar lavage, which showed up malignant cells. Okay, so this patient had a primary pulmonary tumor with metastasis to the eye. So again, the emphasis here is no cells, no inflammation, and so you think of alternatives over there, and fluorescein probably would also have told you that this is also not CSR, and the kind of the tense detachment that you're seeing would make to suspect that there is no harm doing an ultrasound. Okay, so that the emphasis here is that ultrasound has to be used judiciously whenever you feel that the disease is behaving atypically. And the other thing about metastasis is the amount of detachment doesn't correspond to the amount of metastasis. You can have a small metastasis, but a very huge detachment or a very huge amount of exudation. Okay, the two may not correspond at all. So metastasis is what this patient had. So this patient again was sent to me by one of our ex senior residents from, and he's a practicing retina consultant, and he had sent the patient to me as bilateral viral retinitis, and the patient was on antivirals when he came. Okay, so I showed you only the fundus pictures over there, but the moment you see this, it is too similar.
Can you tell me the age and the history of the patient again?
The patient was, I think, 35, 40, Vishal.
Okay, okay.
Okay, so
ARMD is ruled out. ARMD is ruled out.
yes, sir, ARMD is ruled out. Yeah, so this patient, the symmetry, the media clarity, the lack of involvement of the blood vessels. Okay, whenever you're thinking of retinitis, you'll also have some involvement. This kind of symmetric involvement is not very common, and the blood vessels absolutely seem free of any kind of involvement in this. Okay, and because I've seen these patients, I'll show you the first patient that I made a diagnosis of this condition. So now you're more or less comfortable making the diagnosis. This was a patient with bilateral choroidal osteoma. Okay, so because he's 40 years or so, there is a central atrophy that is setting in. But if you look at the margins over here, this kind of an orange solid looking appearance, there's hardly any kind of a surrounding edema that is there. Okay, and many of these cases, again, osteomas are never so symmetric. But since, like I said, I've made these diagnoses multiple times now, so the first consideration in this situation was a choroidal osteoma. You've done the fluorescein angiography over here. There is some tracking that you're seeing, but obviously no leakage. Okay, there is some staining of the lesion. There is some transmitted window defect that you're seeing over here. So this was a patient with a bilateral choroidal osteoma. Choroidal osteoma is a very, very rare tumor, but in these in kind of patients, you will have very good vision. The lesion may look very aggressive, but the patient will have 6, 9, sometimes 6, 6 vision, even if it's just beneath the fovea or involving the foveal area. But in this situation, with time, there is deossification and then they go into atrophy. So what you're seeing here is a central atrophy. So obviously, this patient would not have very good vision, but this is how a choroidal osteoma would appear. Even if you close this eye, you may see these lesions unilaterally. Okay, so this is a choroidal osteoma. So the next patient, so this again was a time when I was a senior resident, and I was there in the old clinic. We have a new clinic and an old retina clinic, and this patient had been following up for many years actually as an epiretinal membrane secondary to vasculitis. So when I was seeing this patient on indirect, again, I didn't see any kind of vasculitis appearance at all. And so I was intrigued as to why this kind of a membrane was there. And so I did the fluorescein, and this is again not very sharply focused, and I'm sorry about that. But this was the picture that you're seeing, that I mean, gross vascular distortion at the macular area. And the younger generation may not appreciate it now, but those were days when we didn't have this kind of internet and so many image galleries, and now there is a glut of images, there's a glut of videos. So we generally we feel, oh, how did you miss this diagnosis? Those were not the days. The books were extremely costly to purchase. But then I went to the National Medical Library. That was the resource point for me. The Our Dikshit Library had wonderful books, but the National Medical Library, which is just adjacent to AIMS, had excellent books over there. So I picked up one of the atlases there, and I was just seeing it. And this is the picture. What I was seeing in the patient, it seemed like it was the same picture that was there in that atlas. So this is a combined hamartoma of the retina and the retinal pigment epithelium. Okay. So then this was the first report from India actually of a combined hematoma. It was published in Ophthalmic Surgery and Lasers. So and like I said, this youngster was actually getting followed up as epiretinal membrane secondary to vasculitis. So for the youngsters, the message is that if you see something unusual, something not fitting into a pattern, try to ask questions, explore more. I mean, when Gas described it, or whether it's the osteoma, the combined hematoma, what they did was they apparently kept these unusual kind of patients separately in a folder or in a bag or file or something like that. And later on, they would put all of these cases together, and then they saw that, oh, they were all fitting into a pattern. Then they analyzed, and of course, they had some access to eyes that they renucleated, taking permission from. So they have a good system there. So they had histopathological evidence and all that. So, but here you can obviously can't do that. But whenever something is not fitting to the common, please don't kind of lose that patient. Keep them under your follow up. Ask your seniors, speak again, discuss, look at atlas, look at the net. But you should get what the diagnosis is. Okay, this is an innocuous condition. I mean, we have then subsequently made a diagnosis in more patients, and we operated on three of these patients. The vision did not improve in all of these three patients, so we stopped operating. But now the younger generation again is more keen on operating, so they've again been doing some of these surgeries. But here again, it is important to emphasize that all combined hematoma of the retina and retinal pigment epithelium can be of varied kinds. Okay, in one, the epiretinal component can be very prominent. In the second, the intraretinal component can be very prominent, and in the third, pigment epithelium component can be more prominent. But what does give away in all of these lesions is that surrounding the area of abnormality, you will see an increased grayness of the pigment epithelium. So, but a surgical decision has to be taken only if the epiretinal component is predominant. If the intraretinal component is predominant, please don't try and do any surgery in these patients. Okay.
Good case.
So this again, this was a patient actually. Again, I was a senior resident, was being treated by one of my young faculty as toxoplasmosis. I mean, I probably also seen the patient, and like I said, I've learned a lot from my teachers. So, but essentially, this patient was not, the lesion was not changing. So, sir said, why don't you just see what is happening? And then out of curiosity, I went and did the ultrasound. The teaching in RP Center is that we have the freedom to do the investigations we want. We were trained to do those investigations ourselves. So I went on, and then I did this. And to me, the thing was that this will be two optic nerves now. If you look at the image over here, that this is the optic nerve, and then there is another high reflectivity lesion, and then you're seeing a shadowing over here. Again, these were days, no internet. So you go back and see when you can have this double optic nerve kind of a situation. And this is almost pathognomonic of a choroidal osteoma when you have a double optic nerve sign. So this also was the first report from India, actually, the first report of a choroidal osteoma. And he was a young patient. Like I said, it looks like a focal patch of retinochoroiditis. But again, if you go back now, everything seems fine. That the vision was good, there was no surrounding retinal edema, and so obviously we should have thought of something else. But if the ultrasound had not been done, we would have not been able to pick it up. Okay, a simple measure. So any lesion like this, you're not able to explain, no harm. I mean, the ultrasound may or may not show something, but there's no harm doing a non-invasive test. Okay, so this was again a patient of the first patient actually of a choroidal osteoma. So now coming back to this patient, like I said, had been referred to the uvea clinic as a patient with uveitis. Now, what identifies uveitis is a constricted pupil, an irregular pupil. So if you see in this patient, the pupil is so regular, it's well dilated, and even if you treat any of these patients, you will probably have some degree. You cannot have blotches of pigment on the lens capsule, but no synechial formation. In this situation, you're seeing the blotchiness on blotchy deposits on the anterior lens capsule, but the pupil is dilated and regular. You're also seeing
As,
patchy.
as I asked you earlier, is there any history of foreign body, intraocular foreign body?
Yes, okay. So obviously this was not elicited. So this patient had a history of projectile injury, and now that the sidrosis is set.
Siderosis.
Yes, sir. This is very typical of sidrosis. Okay, so you're seeing a deposit. This was again captured using the ICAP, Vishal. Okay, long back. So you're seeing the endothelial kind of deposition of the ferrous ions. Okay, so and you're seeing the appearance, the iris heterochromia of the iris. So this is typical of a sidrosis bulbi. And so you should not make an error. And uveitis, like I said, means a chronic situation like this. All of it should fit in. The pupillary signs or the pupillary signs are not fitting in. That itself should tell you that let me look for some alternative diagnosis. Okay.
Yeah. Yeah, this is very common and they should not miss. I have also seen 2, 3 cases of cirrhosis, I mean foreign body, and we had to elicit the history. So
Yes,
in
sir.
case of, even if you are suspecting a uveitis, you should ask the history of any trauma, especially
Yes,
in the profession. I asked you profession for the first time when
exactly.
I saw this,
Yes, sir.
because
Yes.
this is cirrhosis and maybe now what is the, let us ask them what is the first diagnosis or confirmatory diagnosis of cirrhosis? Any investigation? Anybody can anybody reply? How do you confirm
The
cirrhosis?
investigation of choice in this case. If anybody reply in
Cirrhosis.
the chat box.
You can take this as your quiz question, Vishal.
ERG, ARG.
Yeah, G, yeah, G.
ARG, yeah, yes.
So serial ERGs rather, in case of a foreign body, metallic foreign body, if you see one foreign body and he has good vision, and if you want to observe, in case you want to observe, then you should continue doing serial ERGs uh, unless until you remove the foreign body. Am I right, Dr. Venkatesh?
Yes, sir. Yes. And yeah, and Vishal, sir, and yeah, I mean, if somebody can tell us on whose name the classification goes of ERG, they're like sir was saying, there are stages it evolves in. So if anyone can write down on whose name the classification is, I think
ERG
Vishal,
classification is based on whose name? Can anybody answer in the chat box?
yeah, so they'll they'll
That
be
will be
awarded
the
by
honors
Vishal.
question. ISCEV. That is the international standard. This is not a name.
Yeah, the awards will be given by Vishal. Yeah,
Sure, sir, sure.
yeah, Vishal. Okay, yeah. So I have no role in the awards. Yeah. So the next thing again, like I said, the child over here. So this was a shifting hypopion, and the child had a history of leukemia. Is a known patient with leukemia. So the biopsy of we were not very sure. Okay, so we went ahead and tapped this also, and these the cells that you're seeing are from the anterior chamber. Okay, a shifting hypopion in a child with leukemia. The problem for us was the child that otherwise was in remission. The IRCH people said that there are no other systemic features of active leukemia, so we had to tap this, and you're seeing the leukemic cells in the anterior chamber. Again, extremes of age, 5 years old. You're seeing uveitis, like many of you said, GRA. Yes, I mean, you should think of GRA most common cause, but nothing is fitting into the other necessities of GRA. And it's a presentation like this, you should think of a masquerade. Okay, so this is a leukemia a presentation. This child again was unusual in the sense the parents apparently gave. This child was admitted in another unit and had been managed for some time in the other unit. And the parents apparently gave a history of fever, and so a diagnosis of metastatic endophthalmitis had been made, and the patient had been treated with uh, antibiotics, again intravenous and all. And initially they said that the hypopyon had disappeared, and it seemed like the child was doing fine. So this child was sent to our retina clinic, and Dr. Garg sir was there, and I've learned a lot from Professor S.P. Garg sir, and I think he had one of the best clinical skills. Okay, so he was there in the clinic, and then he said, "Has someone seen the other eye?" And the patient had been under follow-up for the last 10 days or 2 weeks or something like that, and nobody had seen the other eye, and the other eye had an obvious retinoblastoma. Okay, so this was again a child with retinoblastoma. What you're seeing again is deposits in the iris. So he didn't even see the child, but he just said, "Has someone seen the other eye?" And the other eye had retinoblastoma, and it had not been done. So it has happened to us, and it can happen again. It has happened as recently as maybe 6, 7 years ago. There was a child. The father came weeping to me in the OPD, and what I felt most, what should I say, very, very disappointed with ourselves was, again, it was admitted in another unit. The child had been admitted as squint, and squint worked up, but nobody had seen the retina. They diagnosed the child with retinoblastoma outside. Everything was there, but there was a casualness in the workup, and that was very, very disheartening. And I mean, obviously, then,
Dr. Venkatesh, before diagnosing this case child as metastatic endophthalmitis,
yes,
was the ultrasound done for this eye? Forget about the other eye. Was the ultrasound done for this eye?
no, the important thing, what I'm emphasizing, sir, it was that the fever history was there. There was a uveitis like this, the hypopyon like this. So a blind diagnosis of metastatic
So
endophthalmitis.
no ultrasound was done.
No ultrasound had been done. No ultrasound had been.
That
And
was mistake
after,
number one.
yes, sir. No, but again on ultrasound, one thing I'd like to emphasize is that there is this diffuse infiltrating form of retinoblastoma, which is only in the periphery, and they generally present with this kind of hypopyon and iris nodules like this, iris deposits. And these diffuse infiltrative form of retinoblastoma hardly has any kind of calcification.
Yeah,
So
it is
there you,
possible, and I agree
yes,
that other eye examination is equally important, but ultrasound
yes.
is also equally important.
Yes, very true, sir. Very true. Yeah. So I'm just highlighting the mistakes that can happen, which should not happen. Okay. So you have only two ways of learning: learn by your mistakes and learn by mistakes made by others. And
Others.
yeah, being in the healthcare, it is always important that you learn by mistakes made by others, because every patient is precious. Okay. You cannot take the liberty of making mistakes at all. So I'm just highlighting the mistakes I have made, mistakes that we have made, and it can happen. Okay, so please try to avoid that. And looking at the fellow has a lot of value. Okay, that's what my other mentor, Professor Tiwari sir, always said. Pradeep, don't look at the eye with the detachment. Always see the other eye. You pick up a tear over there, and you're so involved in the planning the surgery for the eye with detachment. He comes back to you later with HST under a lattice, which you've entirely missed. Okay, so he would always emphasize, please see the normal eye, so-called normal eye first. Okay, and those kind of teachings are very, very valuable. Okay.
Yes, sir. Yes, sir.
Right.
Yes. Yeah. So this patient again was referred to us again by one of my own senior residents. Uh, he was my senior resident actually in practice in Delhi, and it was referred to Professor Tiwari sir again. I used to be with sir in his OPD, and then it was referred as a patient with APMPP. The diagnosis was that, and but what was most striking over here is the pigment that you're seeing on the mass or the lesion, yellow lesion that you're seeing. And these kind of pigments are typically called the leopard spot appearance. And somehow I was working on the manual on fluorescein angiography. So I had gone through some of these images also. And so I was seeing the leopard spot for the first time. And then, so we considered the possibility of a subretinal lymphoma. And she was an elderly lady, again, a very well-to-do elderly lady. And then we did the ultrasound, and you're seeing this is ultrasound of that patient. Okay, so you're again seeing subretinal mass kind of a lesion over here. And this was the first time actually that we were considering the diagnosis of an intraocular lymphoma. And we were not very, what should I say, skilled, or we didn't have the means of doing a biopsy at those days. It was 20 gauge. We didn't have the best of equipments. So we got best of equipments much later. So we didn't consider a biopsy. So I decided we just do an MRI, MRI of the brain, that is. So when the MRI was done, the MRI seemed to be normal. Okay, now again, there was a dilemma. We had no confidence and we had never made a diagnosis of intraocular lymphoma. So we just said that it would still be an intraocular lymphoma. And subsequently, this patient went to Shankar Nethralaya. Okay, so in Shankar Nethralaya, I mean, I probably would not have it. Probably there was an interval of 3 months where they came to us and then they went to Shankar Nethralaya. Somehow they happened to repeat the MRI of the brain, and at that time, the brain MRI had shown up lesions. So when you have lesions like that, obviously the diagnosis is no longer in doubt. But so it's a case of a CNS lymphoma that developed after the appearance of a primary intraocular lymphoma. And this is a subretinal form. This is the subretinal form of the lymphoma that you're seeing over here. Subsequently, we have made, and this was a bilateral involvement in this lady. So we've subsequently made a series of lymphoma diagnosis. Now, in contrast to that, okay, so this was a subretinal as an intravitreal form of lymphoma. This lady already had CNS lymphoma and she presented to us with this. So the diagnosis was not in doubt in this situation, but she had a PR inaccurate kind of a vision. Okay, so and she underwent they have a regime, forgetting the name of the regime now. Okay, so she underwent chemotherapy and then radiotherapy, and when she was undergoing that, the subretinal lesions completely disappeared. Okay, but the vitreous form, vitreous involvement never disappeared. Okay, so this was the when we did the vitrectomy, we sent it for again, obviously. So you're seeing these. It's a low grade B cell lymphoma that you see. So if you see what is the right eye, which had the predominant subretinal form, due to the chemotherapy and the radiotherapy, the lesions have completely regressed. And this lady actually recovered 612 vision until she passed away 3 years after the onset of all this. She was admitted. She was in a very bad condition when I saw her before passing away. So because of all the systemic pathology. Until then, the eye was normal. I'd gone to see her a few days before she actually passed away. So the eye had remained clear. Now, in contrast to that, you see the left eye. This was the vitreous involvement. So there was a mixed involvement in this patient, and the vitreous form kept on coming again and again. So this was the first time actually I spoke to Dr. Ambati in the US, Kishan Ambati, and then he said that Pradeep, we no longer advise radiotherapy over here, and my colleagues say that we give only intravitreal methotrexate. So this was the first patient where I started using intravitreal methotrexate, but after the third or fourth injection, she developed severe keratopathy, and it's a known complication of intravitreal methotrexate. But there was no other option. Again, you can continue giving it with more care. Okay, so I continued giving it, but after the 10th or 11th injection, it became resistant. It would just not go away. So that was the time then I said that we are anyway going and doing biopsy so frequently in patients with lymphoma. Why not do a therapeutic vitrectomy instead of a diagnostic vitrectomy? And this was the first report actually where we did a full therapeutic vitrectomy for a patient with intravitreal lymphoma. And like I said, she remained. In this eye had where she had an early cataract. Within 6 months, she developed a cataract. We had to do a cataract surgery. But after that, the eye had remained quiet, and she again had 612 vision in this eye, also 612, 6-9 vision in this eye. So lymphoma again, we're picking it up more frequently now. I don't know the reason. Maybe diagnosis, we're suspecting it more often. Okay, but this is again a lesion that gets missed. And even in the US, they say there is a mean interval of almost, I think, 7 to 8 months before the correct diagnosis is made. Okay, so any elderly patient, unusual kind of retinal presentation, vitreal presentation, please think of a lymphoma.
Okay, sir.
Yeah, I think we have the last two slides now. So this was, like I said, a young girl, and this again was being seen by one of, I was again a senior resident, and the child was being followed up by one of our young faculty, and the child had been diagnosed actually as viral retinitis, was getting treated as viral retinitis. And since there was no response, she had been admitted in the ward for discussion. Okay, so when this child was admitted in the ward, again, Dr. Garg sir was again there in the clinic, and to take sir's opinion, the child was sent down. And the only thing he said was he did a direct ophthalmoscopy, and he said to go and measure her blood pressure, and the blood pressure was very, very high. I think 200 and 120 or something like that. It was very high. Okay, I don't remember the exact values. And obviously, the whole situation changes. Now, for the youngster, so then the young consultants were taking care of this child asked, sir, why did you do that? So he said, Beta mujhe, I was not able to see the arterioles at all. Okay, so if you see the image, the arteriole, there seems to be so much of exudation that is there, but the fact that there was no arterioles visible had prompted sir to just get a simple test like blood pressure. And subsequently, this child had a pheochromocytoma and was operated at AIMS itself. Okay, so these kind of errors can happen, and the young child would never suspect a malignant hypertension, but pheochromocytoma could occur at any age. And again, what is giving away over here is that the symmetry, more or less symmetry of the lesions, the media clarity, again, a viral retinitis of this nature, unless the patient is immunosuppressed, is not going to have such a clear media. Okay, there is going to be some degree of retin surrounding retinal edema, vitreous involvement, and obviously we are not look for cells in this child again. Okay, so just based on indirect ophthalmoscopic on the color of the lesion is the diagnosis is sometimes made, and we continue. I mean, this is not a rarity. I'll tell you another incident. I don't have the funnest picture. So this was a patient which was had received 3 days of pulse steroids in one of the other units, and the patient had not responded. The exudative detachment was there. So again, they sent for a second opinion, because I had learned from Dr. Gertzer, and for me also, the situation seemed like it was a malignant hypertension. I sent the patient for blood pressure examination, and it was in the malignant range. Okay, but what was more shocking for me again was when I saw the file, the blood pressure had been documented as normal. So I saw which resident had done that. So I immediately called him to the OPD, and he was a first semester resident who had just joined our department. And I said, how could this happen? So his answer was, sir, I mean, many of my seniors write the blood pressure like that, तो मैंने भी लिख दिया था. So we have another level of check that happens. Okay, and we all of us fall into this prey. Okay, we generally follow the culture that the seniors leave behind, and there is element 95% two standard deviations. Everything seems normal, but it's that 5% that you are expected to pick up. Otherwise, it can be extremely harmful. Okay, so this kind of
Agree, Dr. Venkatesh. I also get the blood pressure checked up in such cases, and most of the time, more than 90% of cases, the blood pressure is in the range of 220 by 120, and they are all young patients. They are all
yes,
young patients,
yes.
not so young, but in their early 20s, 30s, actually. So we must check the blood pressure whenever the situation comes.
Yeah, okay. So, and this is a simple test. So please don't neglect it. You may sometimes overdo your blood pressure, but there is no harm. Okay. Yeah. So this is my last slide. So you don't have to actually jump to all. I mean, the immediate thing is that get this, get that. Nowadays, we don't spend enough time. That's a grouse that I have, that we're not really spending enough time on the clinical aspect of our patients. Okay. And that's very, very important. And there is going to be a lot of pressure for you that your friends are going to leave the clinic early, or they're finishing their OPDs early. And so don't get swayed by that. Okay, the more time you spend with your patient during your learning years, the better off you're going to be able to help your patients later on. Okay, so just as soon as you see a patient, don't say just get his OCT done. Okay, your mentors are there, do a 90T, see what the diagnosis is, and then challenge yourself whether the CSR is there or not there. Let the report come back that you may diagnose it as CSR, the OCT may not show any fluid, but you go back and see why that error happened. Okay, so that kind of is evaluation, or is what that I would want the youngsters to persist and keep doing. Okay, so don't get too involved with the advances in imaging that's happening. They may probably be the gold standard, and we may not be able to beat that. Okay, but somewhere along the way, I think it's important that you have the joy of making a clinical diagnosis, and I think that joy was what actually kept us driving. I'm sure Vishal also would, and some faculty there would actually
Absolutely.
support us. Okay, so there's a joy in making a clinical diagnosis, and whether it's a retinal space that you're evaluating, examining the other eye. Okay, so don't really miss those small little details. And with that, I thank all of you who joined the class today, and I'm hoping that the last maybe 60 minutes was of some value to all of you. Thank you all so much. Thank you, Vishal, and thank you,
Thank
sir.
you. Thank you, Venkatesh. Very
Such-
nice and something new. I think all the residents should pay attention to whatever you have written. And OCT also is important because sometimes when the technician does the OCT, I have seen patients being referred for macular hole surgery with the OCT showing a hole. On the contrary, the hole was maybe around 3,000 microns away from the macula. It was, I
Okay.
mean, parafoveal. So he was advised surgery for the hole, and I said just do a laser. So he was lasered. That's all.
Points well taken, sir.
So even OCT should be done at least supervised by the surgeon himself, not being done by the technician only.
Absolutely. So, sir, this has
So
been a wonderful Kaksha by us, sir. And diagnostic nuggets, as he calls it, is a vast topic and lifelong learning. And it's impossible to cover everything, but a very well explained and a very comprehensive and a crisp presentation. Sir, I think you should open archives of the old photographs. You have a great collection there with you. And
Yeah, Vishal.
thank you all the residents, ROS executive, teachers, and especially Dr. Pradeep sir for the excellent teaching. We look forward to the next class in the coming week. And keep giving your feedbacks
thank
and
you.
questions.
Thank
And
you.
subscribe to
Yeah.
the ROS official channel on YouTube. All previous classes are uploaded there. Good night from Team ROS. Thank you, sir.
Yeah, good night. Thank you
Thank
then.
you.
Bye.
Thank you. Thank you.
Bye, sir. Bye.